Afternoon, and thank you for inviting me to present at the Grand Round today. So many different topics to choose from. I had difficulty choosing one, but I opted for one which we commonly get questions asked about. I'm happy to have any questions as we go along, either hand up and chat, or pop it in the chat box, and I'll open it at the side so I can keep an eye on that as well. And so I'm going to go through a couple of cases first, and then have a bit more discussion about the eventual diagnosis. But as I said, do interrupt in between times if you have a burning question. So the first patient was a 79-year-old chap who came to hospital with leg pain. So he'd had a 3-month history of pain in both legs, from the calves to the buttocks and groin area, particularly at night time with cramping, and had trialled some analgesics without great resolution. He'd lost some weight, perhaps unintentionally, and just felt tired and a bit constipated, but that was put down initially to the codeine. He had no urinary symptoms, no numbness, no weakness on neurological examination. That's the wrong button. He'd had a past history of some BCCs of his nose, hypertension, sensory neural hearing loss, a malignant melanoma, and cystoid murmur, which had been monitored on echo. He was a smoker, and previously had lived in Africa as a cattle farmer. Medication-wise, he had no allergies and was taking ramipril, indapamide, gabapentin, cocodamol, and lactulose. And examination-wise, there was nothing significant noted on examination. Now, if I was doing this to an audience of live people in the room, we could go through a possible differential at this stage. The difficulty is a lot of people, both in the community and in hospital, experience pain, particularly bony pain or back pain. So there can be quite a wide differential for that. And for someone who's 79, there could be quite reasonably be some mechanical causes for this. So he underwent some investigations and blood test investigations, and I'll put those up there for a moment to have a look at. And as you can see, there's a mild, very mild normocytic anemia. ESR was raised, some renal impairment, the creatinine of 148, a raised total protein, and a calcium level that was corrected at 3.01 above the normal range. The investigations of his spine, he had an MRI scan because of the persistence of pain in the sacral region, radiating down both legs, and that revealed a soft tissue lesion affecting the L4 vertebra. It was causing some spinal canal narrowing and some compression of the thecal sac. The scan also noted, as often MRI scans do, some inhomogeneous bone marrow, suspicious for infiltration. He also had a CT scan, which, quite unrelated possibly, showed some very impressive polycystic kidneys, as can be seen on the right-hand image. And on the left-hand image, you can see the abnormality at the L4 vertebra. So given these changes, he went on to have a bone marrow biopsy. I'll just put in on this screen here, you can see over time that his total protein had been increasing over the period of a good few months, whilst the albumin had been stable. And that can be seen when there's a protein albumin gap, and that gap is often filled by immunoglobulins, or in this case, a paraprotein. So this gentleman had a 31 gram per litre IgG paraprotein on this blood test here. So he went on to have a bone marrow biopsy. Unfortunately, the aspirate was a bit hypocellular, but on flow cytometry, the immunophenotyping, and on the trophine, there were abnormal plasma cells, which stained for CD138, consistent with a diagnosis of myeloma. So in this gentleman's case, given the location of the plasmacytoma, the myeloma lesion, and its compression of the thecal sac, he had radiotherapy and steroids to prevent further neurological compromise. And at that point in time, he was placed on an oral chemotherapy regime called CTD. I'll talk a bit more about chemotherapy regimes later on. He was also started on bisphosphonates, partly because they are a part of treatment for myeloma, but also because of his hypercalcemia, to try and bring that down. And in terms of what you need to check, well, one of the rarer but more significant side effects of bisphosphonate therapy is osteonecrosis of the jaw. So you have to ensure that they have had dental checkup and that they have good dental health before starting this, to prevent, so that because if you don't want them to have dental work or drilling into the jaw once they are on bisphosphonates, if you can help it, or certainly not without a good break, because it can lead to this osteonecrosis of the jaw, which is a really difficult thing to manage and can be quite distressing. On the second case, we had a 67-year-old lady who had a past medical history of a laminectomy and hypertension, and she'd had some worsening back pain with a history of weight loss and then lethargy. And at that point in time, the calcium levels were normal, kidney function was normal. Just something to note for later on in the discussion, the protein was raised, 83, normal level is usually up to 80 with a normal albumin. And she came to A&E with worsening back pain, where a possible diagnosis of a kidney stone was being explored, and so she had a CT-KUB. And this is a section of the CT scan of the pelvis. And as you can see here on the left-hand side, there is a destructive lesion affecting the left iliac crest, which is not present on the right. And you can see that these bones are, even with my non-radiological eye, relatively mottled with some lytic lesions within them. Again, she went on to have MRI imaging, which is a mainstay for most patients now in terms of MRI of the whole body to look for bony lesions. And it showed extensive lytic lesions throughout the skeleton, as well as as multiple vertebral body fractures that you can see here, which should be in keeping with the disease process. So, well, the main differential here is myeloma or another metastatic malignancy. At this point in time, there was a mild increase in the creatinine to 129. The full blood count was reasonable, although hemoglobin was just at the lower end of what would be acceptable for a lady, lower end being 125. And the calcium level, as you can see, corrected, was raised at 3.28. At that point in time, she had some further blood tests looking at an immunoglobulin profile. I will talk about that in a bit more in detail. The IgG level itself was at the upper end of normal, but the IgA and IgM were slightly suppressed. When we did protein electrophoresis, there was an 11 gram per litre IgG kappa paraprotein. But in this case, the serum-free light chains, which have generally replaced, for the most part, urine Bence-Jones proteins, showed quite a significantly raised kappa chain of 5,000 with a suppressed lambda chain of 1.5. And we measured that as a ratio. That's over 3,300. So she went on then to have a bone marrow biopsy. Again, unfortunately, we must get better at this, but again, another hemodilute sample, so that means we don't get enough particles out. But when we send it for flow cytometry, there are abnormal CD138 positive plasma cells within it. And again, the diagnosis here was of myeloma. But going back to this slide here, with this very high light chain ratio, this would be a light chain myeloma. So given the hypercalcemia, she was treated for the hypercalcemia with fluids and permidronate and steroids, as well as some oxycodone for the pain. She was started on a treatment called Velcade cycloindex, which is often favoured in people who have light chain disease. And as she was younger and fitter than the previous gentleman, she was considered for an autologous stem cell transplant, which is standard treatment for fitter patients after first-line treatment if they obtain a remission. So, unsurprisingly, in haematology talks, we're talking about something hematological, and that is multiple myeloma or myeloma. In your bone marrow, as you remember, there are plasma cells that produce antibodies of varying different types. Hopefully, for most of us, some of them have antibodies against COVID from our vaccinations, but there'll be lots of different antibodies produced by these plasma cells. But in myeloma, there is a clone developed, so a single clone of or subclone of plasma cells that are all producing the same antibody, the same protein. And that is what we measure as a monoclonal protein, or a paraprotein, you may hear us describe it as such. And that is what, or light chains. And that is what characterizes myeloma, these abnormal plasma cells. It is relatively common as we get older, as with most things. It increases with age. It's quite rare to get it in the younger age groups of between 40 and 50, but it does happen. There is an increased incidence in Afro-Caribbean populations compared to Caucasians. And as you can imagine, in an area such as East Sussex with an elderly population, we do see a fair amount of myeloma in this region. Most people will present with some form of bone pain or fracture, although, as mentioned, it can be quite difficult to discern these from simple osteoarthritic changes, particularly again in the elderly population. There'll often be impaired renal function, anemia, which is often normocytic or normochromic, hypercalcemia, and increased susceptibility to infections, because as the plasma cells are producing abnormal immunoglobulins, there is a suppression of the normal immune globulin production, and people do become more susceptible to infections or have more difficulty in clearing those infections. In some patients, particularly those with IgA paraproteins, there's an element of hyperviscosity, where the paraprotein can be very high, and people can present with headaches or visual disturbances or even cardiac failure due to the hyperviscosity. And of course, anyone who has any neurological symptoms or difficulty passing urine combined with back pain needs to be considered for myeloma and have cord compression ruled out early on. The raised ESR, I've gone wrong one. Raised ESR is not specific to myeloma. We often do get referrals come through, for people who've got a raised ESR. The raised ESR is a function of hyperviscosity. It's a function of having a high protein level in the blood, which results in a slower settling of the red cells, the erythrocyte sedimentation rate. So it is a surrogate in some cases for myeloma, but it can equally go up in inflammatory conditions, autoimmune conditions, hepatitis, any malignancy where you've got a polyclonal increase in immunoglobulins. But if it is raised, then that should drive one to make sure that myeloma is not a cause here. So diagnosing myeloma, well, this, just for imaging's sake, this is a plasma cell that you would find in usually the bone marrow, which has this little pale area next to the nucleus. And they're usually quite a nice bluey purpley hue. So diagnosing myeloma, there are, as with anything, it's a continuum. People can have an abnormal paraprotein and have nothing, no end organ damage, and have no excess of plasma cells in the bone marrow, and they're termed MGUS. You may see a lot of those around, MGUS, which is very common as we get older. But there's a continuum between that and smoldering myeloma or asymptomatic myeloma and myeloma. To have full-blown myeloma, you have to have either an abnormal paraprotein or raised serum-free light chains. You have to have an excess of plasma cells in the bone marrow, so usually at least 10% of clonal plasma cells. And you have to have end organ damage. So these are often called CRABs, so hypercalcemia, calcium, renal impairment, anemia, or lytic bone lesions, CRABs. And they are end organ damage, they're myeloma-defining conditions, and in those patients, treatment is required. So basic workup, as with most patients, is a full blood count biochemistry profile, serum protein electrophoresis, and into that I'd also add serum-free light chains. In terms of imaging, in the past, skeletal surveys used to be done, but these days, for all those, apart from those who can't tolerate or can't go into an MRI scanner, all patients will have a whole body MRI, as it's much more sensitive for catching earlier stage disease than skeletal surveys are. Often, if you see a good lytic lesion on a skeletal survey, the patient is quite advanced in their disease. And then the bone marrow aspirate and biopsy to determine the level of plasma cell infiltration. Now, the biochemists on this call will know much more about this than I do, but this is a plot of a normal protein with electrophoresis in green and a spike paraprotein when you are running it for someone who has myeloma. I think that's about where my expertise ends in that one, so I'll quickly move on before Sue and other else come in and tell me I've got it wrong. As I mentioned, predominantly nowadays we do MR imaging. For those who are claustrophobic or for any particular metalwork reason can't go in an MRI scanner, a whole body CT looking at bony windows can be used. It's very rare that we would use as a screening tool at baseline any imaging such as plain radiographs. In some people, there is an unusual type of myeloma called non-secretory myeloma, where it can be difficult to determine how well someone is doing purely from the blood tests because you can't monitor their protein levels. And in those patients, imaging becomes much more important as an assessment of their response to treatment. And MR and PET imaging come into their own in those circumstances. As mentioned before, people need to have CRABs to need treatment, so hypercalcemia, renal impairment, anemia, or lytic bone lesions. And this is the flow between MGUS, a monoclonal gammopathy of undetermined significance, which is quite common and just needs monitoring, asymptomatic myeloma, where they don't have end organ damage, but do have more than 10% plasma cells in the bone marrow that are clonal, or a paraprotein up to 30 grams, versus symptomatic myeloma. And this is a bit of a continuum. So some patients who have MGUS, where their paraprotein's 1 or 2 grams per litre, very low levels, we can safely discharge them to their GP for monitoring every 4 months or so, 4 to 6 months, because it is unlikely that they'll ever need treatment. There's a 1% per year risk of someone with MGUS progressing to a myeloma. Higher risk MGUSs, those with a higher paraprotein level, will often be monitored in our clinics, and certainly those with asymptomatic myeloma will definitely be monitored. Although even still, some of these patients will not ever progress to myeloma and will just be monitored. And I do have some patients who've been monitored in clinic with very high protein levels at this sort of level for nearly 20 years, and we just say hello every 6 months because nothing has changed. But they are at higher risk of progressing to symptomatic myeloma, so they are watched more closely. Paraproteins are not just found in myeloma, they are found in obviously MGUS, amyloidosis, lymphomas, including and CLL. But they're also found in things like solitary plasmacytomas, which is a form of a myeloma where the abnormal plasma cells are only in one location. Now, patients who have a solitary plasmacytoma can sometimes be treated just with radiotherapy to that area if it is truly confined to one location. But a high proportion of people with a plasmacytoma will go on to develop myeloma in time, so they are also monitored. But if that plasmacytoma is producing enough abnormal paraprotein, you will see it in the bloodstream. But they won't necessarily have plasma cells throughout the bone marrow. They won't have myeloma, but they still have to be monitored closely and treated locally if need be. The anemia, as I said, is usually normocytic and normochromic. Lots of possible causes: bone marrow replacement, renal impairment, and once we've got hold of them, chemotherapy. It's managed, well, usually it responds to treatment with the chemotherapy if it's down to marrow infiltration. Occasionally we use EPO injections for some patients. And of course, common things are common. We need to make sure that they are not iron or B12 deficient as well. Renal impairment happens in about 20% of patients at diagnosis. There are some patients, thankfully a minority, but for whom the presenting complaint is with acute renal failure. They've become acutely unwell, and the creatinine is often over 1,000 on admission, and that is sometimes their presentation of myeloma. But there are the lists of possible causes of renal failure linked to myeloma. Management of that, well, if it's extreme, of course, is dialysis. And once started on chemotherapy, some patients will regain their renal function back to baseline or near baseline. But for some, it can be a long-term impairment, and they will require long-term dialysis. This is a rather old X-ray, but you can see quite nicely, or not nicely for this patient, how lytic lesions can occur within bones, and in this case, a pathological fracture has occurred through that lesion, where there'll be a significant weakening of the bone. And for some patients, that is a presenting symptom by the orthopedic team, having had a hip fracture or a femoral fracture with very little trauma, very little impact, and often reamings will be sent from theatre and will show abnormal plasma cells. This is just a little bit about hypercalcemia in myeloma bone disease due to increased osteoclastic activity and decreased osteoblastic function. And there's a number of pathways by which that occur. And that's one of the reasons we use bisphosphonates for 2 years after starting treatment on these patients on a monthly basis, even if they're not hypercalcemic anymore. This is another classical X-ray of the skull, showing a number of lytic lesions, the largest one being shown by the red arrow there. Again, we don't tend to see these pictures anymore, which is why the X-rays are always very old, because we do MRI scans instead, but the issues are the same. One of the reasons we do imaging at baseline for these patients is to catch other areas of damage. Sometimes people will come in with a vertebral fracture or something like that and get diagnosed with myeloma. But they may also have lytic lesions or deposits in, say, the pelvis or the hip. And if there is cortical thinning, then on occasions, prophylactic orthopedic surgery is given to stabilize that joint rather than waiting for it to fracture in the future. As mentioned before, bisphosphonates. We tend to use zoledronic acid these days, as long as renal function is sufficient for that. Spinal cord compression, as just to touch on, if it's ever considered, the first thing to do is to start them on steroids and to get an urgent MRI scan. There is a spinal cord compression pathway, this trust, whereby the scan should happen within 24 hours. The MRI whole spine should happen within 24 hours of referral. And out of hours, that can be done via the oncology team at Brighton. And within hours, it's often a lot faster done internally. And then a neurosurgical referral. In some cases, treatment will be with radiotherapy, and in some cases, it'll be a surgical decompression, depending on what they see. But if there's any index of suspicion, any change in bowel habits, neurological deficit, any new urinary retention, anything like that, in someone who has back pain, hypercalcemia, renal impairment, any of these things, then we need to think about spinal cord compression as a possibility. Treated hypercalcemia, hopefully you'll be quite familiar with, but hydration and steroids and bisphosphonates are the mainstay. And then once we have a diagnosis, the treatment of the myeloma with the chemotherapy will equally bring down the calcium level. As mentioned, other possible complications of myeloma include infections, hyperviscosity if the proteins are high, and for some patients, they have a coexistent amyloidosis, which has its own complications. So this is really just the crabs again in terms of indications for treatment. So anemia, hypercalcemia, renal impairment, bone lesions, or if there's an extramedullary plasmacytoma. And this, I got this from an old slide. I put it here really just to amuse myself at how much things have changed. This is only a few years old, but the regimes we have now, some are the same, but some are completely different to this. So the treatment options for myeloma are changing rapidly. At the current moment, there are a number of options we can have first line, but for anyone who's fit enough and well enough, they should always have intensive induction treatment followed by an autologous stem cell transplant if they're fit enough, or if they're not fit enough, then we can change the regime to be either oral or subcutaneous, depending on their personal circumstances. But there are lots of new treatment regimes now, and life expectancy used to be, well, they used to quote between 5 years, 6 years after diagnosis for myeloma. But nowadays, in general, it's a lot longer. We have 6, 7, 8 lines of therapy we can often offer people with different modalities of treatment, including monoclonal antibodies, and in the pipeline, some CAR T cell type therapies, although that's not mainstream yet. So the treatment protocols change all the time. And so I don't think anyone will be brave enough to rewrite this now, because it'll change every 5 minutes. So in summary, I've done a fairly whistle-stop tour of a couple of cases of myeloma, one with what we'd call standard or heavy chain myeloma with paraprotein, and one with a light chain myeloma. And I've talked a little bit about the diagnosis and management of myeloma. Some of one of my take-home points is have a look at the total protein. On those initial bloods, if someone has a high protein level and a normal or a low albumin, we have to ask ourselves why. And we have to then check for a paraprotein, because that's often how it's first detected. And the next take-home point is if high protein levels or high light chains doesn't necessarily mean you have myeloma or need treatment for myeloma. So do give us a call. There's always a haematologist around for advice. Thank you. Any questions? It's always very difficult, these things, not being able to see people. Okay, you can put them in the chat box if you want to. Okay.
Thank you very much.
Thank you very much. Yeah. All right. Well, thank you. I think I'm only going to be presented today, I think. So very good.